Hi viewers, welcome back. We are so excited to be back on the screen with you once again. This is your host, Dr. Roslyn Odhiambo, and I am here on Skills versus the Midwife. We want to do a discussion today on managing postpartum hemorrhage. There are a few updates that have come here and there, and since these updates have been put out there as a recommendation, they are also being rolled out slowly. So most of our facilities, they are also picking and taking this, and some of them are doing very well. So today I'm not alone. I have guests with me, and as you can see, they are charged. They are very prepared to have this discussion, and like I said, they are going to help us to understand more about what updates have come up in managing PPH, that is postpartum hemorrhage. So I would like them to introduce themselves. You can start with you, Christine.
Hi viewers, my name is Christine Jambi, a nursing student currently at 4.1.
Okay, thank you, Christine.
Okay, good morning viewers. Dennis Mutuma from Preventable University, a student, ready to discuss PPH.
Thank you, Dennis.
Hello viewers, my name is Lewis Gitahi. I'm a fourth year nursing student at Kirinyaga University, and I'm excited to be here.
Thank you so much. I'm excited to have such wonderful panelists. And today, people, just to fasten your seatbelts, because you may not hear any of this discussion anytime soon. So you need to come around and listen to what we are going to discuss. And there's one more thing I would like to say. Being students who have rotated in labor ward or in the maternity units, they have had first-hand experience. And today, I want us to listen to them. Minimal interference from me, just listen to what they are going to say. How has their experience been on the ground? We have the theory part, but we also have the practical part. So is it working? Is it not working? What is being recommended? Is it something that is actually working or not? So for example, let me get back to you, my panelists. A mother has come to deliver, for example, in the ward, and you realize that she's presenting with signs of postpartum hemorrhage. Can we maybe remind our viewers what are some of these signs of postpartum hemorrhage? How do you actually end up with the diagnosis of postpartum hemorrhage? Let's hear from you, Dennis.
How we diagnose or how we come to know that this is postpartum hemorrhage. If the mother has delivered through the spontaneous vaginal delivery, you have a blood loss of more than 500 mils. If it's via the cesarean section, more than 100 mils, or any maternal, any distress or any condition deteriorating the maternal status, the mother can be having PET, the mother can be having diabetes. So we see the blood loss, we have also hypotension, tachycardia, because we are losing blood. So that is time to pump the blood. So here, for us, we need to now prevent that. So let me show you. Yes.
So actually, we can actually know the blood loss. Yes. How can we know that this woman has lost 200 ml? Is it possible? Is there something we use, or how do we actually know that this woman has lost this amount of blood? What do we use in the facility, Dennis?
Whatever we use in the facility, we have the V drips.
The V drips, okay, all right.
So it measures the blood immediately after the second stage of labor now.
Okay.
The blood is collected through the V drip.
Okay.
The hospital has the V drips.
Okay. So there are actually parameters that will tell us that this mother has lost this much blood and you need to take care of her because PPH is setting in. Are there some women with special conditions who we will be worried if they have lost a certain amount of blood levels?
Yes, I feel like in as much as we are trying to consider the standard blood loss that we have learned about, let's say the way we say when a woman loses 500 mils, for example, through SPP, I also feel like sometimes it's good to consider that there are certain women in certain conditions.
Yes.
For example, a woman with anemia, you might not expect that the 500 mils will be the hallmark of an indication for PPH. A woman who has anemia, for example, let's say if she loses about 100 mils, that's almost like the 500 mils for a normal healthy woman. So sometimes I feel like the best thing to check is the signs and symptoms. Those are the main indicators. Yes.
Very good, Dennis. Well put, well said. So yes, we just don't generalize it. We have special clients who actually may be setting into PPH, and we need to be keen about it. So look at all the signs. Now, let's get into now the aspect where now we want to see what is this update that has come up. What is this recommendation that we are now trying to roll out? We all know the management of PPH, but there are some few so that we normally call it the first response. This first response, what does it entail? The mother, yes, you've confirmed, yes, you've lost 600 ml of blood, you have, you're getting to hypotension, you're dizzy, all those signs you've already confirmed. So let's hear now your experience. You've already diagnosed a mother with PPH. And of course, the first thing, now you see we are discussing an emergency here. Ladies and gentlemen, students who are listening to me, every emergency that you meet in the ward, you always start by calling for help. You cannot take care of an emergency on your own. So we have already called for help. So what is this that we want to do? Let's understand the first response. What is this? Any one of you can take the floor now.
Okay, the first response, after you have called for help, you immediately have to set in for action. It's an emergency, we can't waste time, we need to save the mother's health. So immediately after you have called for help, you have to assess using the inverted J, so that you may know. For instance, if the mother didn't have a cannula, you have to insert the cannula, because the method in which you're going to use to manage the PPH, it requires us to insert the IV fluids and any other medication that we'll get to see it in details. So first, after calling for help, assess the pulse points with an inverted J. First, you use the radial and the ulnar pulse, move forward to the brachial pulse and the carotid pulse, but you have to assess each on its own. Then the brachial, that's when we called for help, so that after you assess here, the other person is cannulating, so that we set into direct management.
Wow. And why are you assessing?
For the pulse points, yes. When we checked on the signs and symptoms,
yes,
one of it is tachycardia.
Very true.
Tachycardia, so there is no point for us to insert the cannula if you are not sure of where the pulse points are.
Well explained. Okay, so how do we move from there? We've already assessed. So let's pick it up from there. Let me hear now your experience. Okay.
Yeah, first I'll start to say the EMOTIVE is the first best management so far, according to my experience in labor ward. I'll start direct with the abbreviation, the EMOTIVE. Okay. First of all, it's for the early detection. We have detected the blood loss is warning sign, 300 beats is above that, the mother's maternal health is deteriorating. So the next step is you must search the family. Because when you check at it, the uterus not contracting is one of the main causes of PPH.
Wow. So wait a minute. If that is one of the main causes, ladies, are there any other causes that we could probably be looking for as we manage this mother?
Yeah. So in the world, we usually say that PPH is mainly caused by the 4 T's.
Okay.
We have the first one that she has mentioned, which is uterine atony. That is the tone. That the first T stands for tone. Then we have trauma. Trauma, basically, we have things like
in trauma, we have things like laceration,
tears, even episiotomy, if you actually did an episiotomy.
Then we have tissue, and then we have the final T, which stands for thrombi.
Very good. So we are now even reminding ourselves that anatonic uterus is not the only major cause, but it is one of the main causes of PPH that we normally have. So she started very well. We are using the EMOTIVE. So we have done early detection. We are now massaging. How do we proceed from there, Dennis?
So using the EMOTIVE, as my colleague has said, after you massage now the uterus, of which we say the atonic uterus causes 70% of the PPH. So from there we continue to administer oxytocin. Already we have calibrated. How do we administer oxytocin? We administer 10 international units of oxytocin in 500 ml of monosaline. And because this is an emergency, this is supposed to run as fast as possible. On the other hand, because also it has a cannula, we give transaminase acid.
Okay.
It is 1 gram. With this an antifibrinotic, so it prevents the clot formation, which increases.
Yes. Actually, we are very keen to make sure we don't have any clots forming, because we need to get rid of all that. Clots is another big problem we can actually have in managing a mother with PPH.
So after you have just already given the first step, the 10 international units, you have given 1 gram of TXA, but we may not have achieved now to stop this PPH. We repeat again, 10 international units in 500 ml saline to run within 10 minutes.
Yes.
But we should not exceed the 40 international unit of oxytocin. So from there, if it's not working, we need now to escalate.
Okay.
So in escalation here, we can use the NASG, the anti-pneumatic garment, shock garment. We can use the UBT, uterine balloon tamponade. Yeah. If it was in a hospital which does not have these facilities, we refer. Okay. Yes, but we refer when we have used already the NASG.
How available are these, the UBT? For example, the facility you rotated in. Have you ever seen a UBT before?
Yes,
You've seen it. You saw it there where you are. Ladies, have you seen one?
Yeah.
A UBT? All right, fine. You know, we may be talking about things that people don't have an idea. And now there's one more thing you mentioned, the NASG. Yeah. Probably in the next video we'll just demonstrate how to actually use them and how does a client now have them on their body. We have the process of wearing it or inserting it in the body, and also the process of removing it, and even how to clean it after in the UBT. So maybe we can preserve that for the next sessions we'll be having, but today let's just focus on some of these that we are working, some of these updates that we have. So now we have done tranexamic, and I believe you're following us when we are saying EMOTIVE, I think. Have we reached the last part, Lewis?
Yeah, we're almost there.
We are almost there. Okay, finish for us.
So now after administering 1 gram of tranexamic acid, now we get to the IV part. For the IV, it stands for administering IV fluids. Remember, if the mother is losing the blood through the bleeding, she is also losing a lot of body fluids. So that's why it is important to administer the IV fluids, which basically include normal saline at the hospital setting, sometimes even ringas lactate. For example, there was a time we were managing PPH at the hospital. The mother had lost a lot of blood to a point she had even started getting serious, because remember, as the bleeding is taking place, the brain is getting hypoperfused, and there's also a lot of electrolyte imbalance. So that's why IV fluids like ringas lactate are important, because they're going to try and balance by replacing the lost electrolytes. Then after the administration of IV fluids, now we get to the last E, which stands for trying to look at what had caused the PPH.
Okay, so it's more of like we want to evaluate. Is there a point where all these processes we have done can actually fail? We have done all this. The mother is still bleeding. Of course, there's a center in the brain that normally controls bleeding, and it produces a hormone that will take care of the contraction to take place, so that we have the uterus back and also the bleeding stopped. So could it be that there's damage? Is there a point where it can actually go surgical? And if we go surgical, what procedure will we do?
Sometimes we may try this and it may not work, no, we intervene surgically. In the surgical team, we have different things they do. We have the beeline suturing. These were the breast sutures. They suture at the vessels around the uterus where there is bleeding. We also use the uterine artery embolization. We administer embolic agents to the uterine arteries. Now, see, we are trying to stop blood flow. As we stop blood flow to this, now we are trying to stop bleeding. Another thing that we can do is the systemic devascularization. This we ligate.
Okay.
Yes. Also, you can do a hysterectomy.
Hysterectomy. Yeah. So hysterectomy is what, Christy?
Total removal of the uterus.
Yes, so we can actually decide to remove the uterus. Yeah. So that at least we can help this trouble of bleeding. The minute you see bleeding is not stopping, it means the control center is also damaged. That condition is normally called what? Pituitary necrosis. So yes, PPH is serious because it actually interferes with the normal outcomes for the mother and the baby. And because this is quite a serious condition, we say that we are here. We are here to encourage all of us to be partners in action. What I mean by partners in action is that everyone here is responsible for a life that could have actually been preserved if we actually took care of a mother who is bleeding after delivery. Let's hear a parting shot from my team here.
So I'm grateful for the opportunity. So as we have learned at the hospital setting, mainly in order to get an achievement of whatever you're trying to manage, you need to have a lot of unity. For example, the EMOTIVE, it's not something you can really perform when you're alone. And also, when we talk about these basic protocols, for example, the EMOTIVE, when we start with the E, more, and it doesn't necessarily mean that you have to follow them in that sequence. For example, something might be happening, let's say, concurrently. Let's say, for example, as you are administering the oxytocin, someone else might be administering the TXA, then also trying to look for the signs, another person may be administering the IV fluids. So what I can say is, these protocols are just a standard, or let's say a guiding tool for what you're supposed to do.
Thank you very much, Lewis. That is good. I think that parting shot is very important. Teamwork in labor ward is everything you need. So thank you, Lewis, for that. Yes, Lewis.
So as we part, mine is just to emphasize on something. Let's tell our mothers there outside, they go for their antenatal clinics, because as they attend these antenatal clinics, they are told different ways on how to eat, and now through this they are able to manage anemia, which is a major cause now, which is among the causes of
risk factor.
Maternal anemia is a risk factor in PPH. So, and also to the healthcare practitioners, let's do the active management of that stage.
Yes. still is active management of third stage of labor. And actually with the recommendations also have a review. We are not only using oxytocin for Amstel, what else are we using?
We are also using carbetocin.
Carbetocin. For centers, for areas where we don't have carbetocin, we can still use the oxytocin. Okay, thank you very, very much, Dennis, for giving us that parting shot. And I would like to emphasize once again that Amstel is very, very important when you're managing any woman who is in labor and has just given birth, because most of the complications that actually we get in labor stems from the third stage of labor. So let's listen from Christine as well.
Okay, in my parting shot, I will emphasize on starting breastfeeding within the first 30 minutes to 1 hour, because breastfeeding assists a lot. In the production of prolactin, it also stimulates the production of oxytocin, a very major hormone which helps in the uterus contraction, thus preventing secondary PPH.
Very good. Yes. Wow, that's a good one. Remember, mothers who are lactating, you see, sometimes you may wonder why we keep telling you start breastfeeding within a span of 30 minutes after delivery. The oxytocin will help in the contraction of the uterus. Remember, one of the major problems of PPH, causes of PPH, is a uterus that is not well contracted. So thank you very much, Christine, for giving us that. And finally, we are coming to the end of this discussion, and I hope that most of us who are watching us today have really benefited. Remember, PPH is preventable. Number one, as I conclude, is that we need to have good birth preparedness for all our women. That means we expect all the mothers to come to the clinic so that we can guide them, we can talk to them, we can educate them, we can teach them on some of the danger signs that they can see, and even identify complications early enough that could actually lead us to having postpartum hemorrhage. So once they are informed, it means therefore that they can actually have informed decision making. And finally, I would like to say that for all healthcare professionals, the students listening to us out there, the knowledge, the skills, and the expertise is what will help us to manage these women most appropriately. Once again, PPH is preventable. Thank you very much, my panelists, for being here. And I would like to say that we are up for more, and you are welcome for the next session. And for now, it is bye from us.